Thank you very much for the kind introduction, ladies and gentlemen. First of all, I would like to thank also Noor for having invited me to come to this nice place and share with you a few ideas about the medical treatment of renal colic. I will include some pathophysiologic aspects. Today, I will not include what we call medical expulsive therapy. I will talk about that tomorrow. So basically what we are going to talk about is what harm does a rolling stone do to the urinary tract system. Ureteral colic. If you have unilateral total obstruction by a stone, there is abrupt distension of the renal capsule and pelvis. This causes the terrible pain that our patients are experiencing. There is, of course, as a consequence, hyperperistalsis of the obstructed ureter. And finally, an increased pressure, not only in the renal tubuli, but also in the glomeruli, and there are prominent hemodynamic changes. For the sake of time, I cannot go into detail about hemodynamics, but just let me give you an example. In dogs, if you have for 1 week a complete unilateral ureteral obstruction, what is the consequence? On release of the obstruction after 1 week, the GFR will be 25% of normal. 2 years later, GFR is only up to 50% of normal. So you lose kidney function if you do not take care of the obstruction. A persisting, irreversible changes can occur if obstruction is not terminated quickly. So that's the goal, to terminate obstruction. Now, as you all know, the ureteral peristalsis is brought about by atypical smooth muscle cells which generate an electrical pacemaker potential in the calyces. And there are other electrically active cells along the urinary tract with pacemaker potentials that are propagated to typical smooth muscle and interstitial cells. And there is a gradient. The further you get down towards the bladder, the fewer cells you have. So you can see peristalsis as a myogenic phenomenon, as a series of electrically active contraction zones. Now, knowing this, what is the treatment goal in renal colic? There are basically two. If you think about the situation proximally from the stone gets stuck. The goal would be to reduce pacemaker activity in order to reduce the terrible pain that the patient has. Once the stone starts moving, you would like to increase pacemaker activity in order to increase proximal pressure, and stone expulsion then would be facilitated. At the stone, or distally of the stone, dilatation of the ureter is desired in order to facilitate stone passage, what we call now medical expulsive therapy. So the situation is quite complex. The contraction waves in the ureter are receptor-mediated, either cholinergic, adrenergic, or non-adrenergic, non-cholinergic. The modulators are numerous. This is a list of modulators that has been shown experimentally. Contraction is brought about by alpha receptors, muscarinic receptors, purinergic receptors, prostaglandin F2 alpha, and so on. On the other hand, you have relaxation, beta receptors, nitric oxide, histamine, prostaglandin E1 and E2. You see already here the prostaglandins are double. There is contraction by prostaglandin F and relaxation by prostaglandin E1 and E2. This is an incomplete list of what has been tried and published in the literature, how you can treat renal colic. Except the analgesics and the spasmolytics, which you all know, there are the alpha blockers, the calcium channel blockers, steroids, intranasal desmopressin, nitrates, and so on. It goes down to things like local anesthetic and pointillage, intravenous lidocaine, lumbar or even transvaginal novocaine block, of course, emergency ESWL. So it's the whole variety, and the matter is rather complex. So let's look at that from a more scientific, evidence-based point of view. What has been tried and published in controlled trials? I was surprised that paracetamol is doing quite well. If you compare IV paracetamol 1 gram versus IV morphine 0.1 milligrams per kilogram body weight versus placebo in a randomized trial where the primary endpoint was the delta in pain 30 minutes after admission. Paracetamol did as well as morphine. Paracetamol versus a non-steroidal anti-inflammatory drug, randomized trial, primary endpoint, pain relief after 90 minutes. Paracetamol was better than piroxicam, actually. Let's go to the non-steroidals. They have a sort of Dr. Jekyll and Mr. Hyde pattern, which comes from the pathophysiology I was just explaining. Because renal prostaglandin F2 alpha promotes ureteral contraction, so increases pain, and prostaglandins E1 and E2, on the other hand, inhibit contraction and therefore reduce pain. So if you give a non-steroidal, you may antagonize the prostaglandin-mediated effects of both and thereby either promote pain or reduce pain. That's the question. Now, if you look what the non-steroidals do in comparison with placebo, on the left side, there is clear advantage. There are good painkillers. There's much less pain than with placebo. If you compare on the right, non-steroidals with other analgesics, there is significantly better effect of non-steroidals. Whether this is clinically relevant in an individual patient, it's not clear. There is always a however. In patients with pre-existing renal disease or patients whose renal blood flow depends on prostaglandin synthesis, the administration of non-steroidals could induce acute renal failure. Now, in the very well-known meta-analysis from Hollingworth, published in The Lancet 6 years ago, the question was raised, do non-steroidals facilitate stone expulsion? So it's a medical expulsive therapy. We know they are highly effective in the symptomatic relief of acute renal colic, yet the only randomized double-blind placebo-controlled trial to investigate the effects of non-steroidals on stone passage showed no difference between non-steroidals and control. Because many physicians believe that the non-steroidals might take care of the inflammation at the obstructed stone, but obviously it is not clinically relevant. Now, Buscopan, many people are still using that, at least in my country. This is a trial with 178 patients, acute renal colic, all were on morphine, rescue indomethacin, and then Buscopan versus placebo. No difference between Buscopan and placebo with respect to the total morphine dose and with respect to the additional morphine doses that had to be given. And the conclusion was there is no evidence that Buscopan reduces opioid requirements or the need for ongoing opioid analgesia in acute renal colic. Now, metamizole dipyrone or novamine sulfone is a very effective drug. It's spasmolytic, antipyretic. There is no anti-inflammatory activity. And the indications are moderate to severe pain and certainly colics, whether in the ureter or the biliary system. Many physicians have been taught, as I have, it's very dangerous to use this drug because of adverse reactions, but it has to be stated clearly, it is very rarely that agranulocytosis occurs, it's irreversible, and very rarely that anaphylactic reactions occur. It's more frequent if you administer it intravenously or in patients with a history of bronchial asthma, alcohol intolerance, or chronic urticaria. This study was comparing metamizole versus Buscopan versus tramadol, a weak opioid, in patients with acute renal colic pain, randomized either to one of these drugs. 2.5 grams novamine sulfone versus 100 milligrams tramadol or 20 milligrams Buscopan. And as you see here, the pain intensity after 30 to 120 minutes was clearly lowest with novamine sulfone and much less with Buscopan and tramadol. In the sum of the pain intensity difference was significantly better for metamizole novamine sulfone. Now, what about the opioids? There are ancient studies in the 30s, 40s, and 60s of the last centuries They proved either increased ureteral peristalsis, decreased ureteral peristalsis, or no effect of ureteral peristalsis with morphines. The Cochrane Renal Group reviewed 20 studies, 1,600 patients, and they stated that non-steroidals had slightly but not significantly better efficacy than opioids for relieving pain in acute renal colic, but fewer adverse events. Patients receiving non-steroidals were significantly less likely to require rescue analgesia than those receiving narcotics. So the opioids do not that well, but nevertheless we still use them, and we have to use them in some patients. In a double-blinded randomized trial with 94 patients, morphine was compared with pethidine intravenously, and the endpoint was pain 30 minutes after admission. The pain score between morphine and pethidine was not different, and the conclusion was morphine should be the opioid of choice nevertheless for acute renal colic, as it does not have the potential for the problems that are of concern with pethidine. And I also would like to warn you a little bit, pethidine can cause addiction much more than morphine does, because it had a very fast onset of action, a rush, short half-life, and the effect lasts only 1.5 to 3 hours. And in the cerebrum, it inhibits the monoamine transporter, and it has a euphorizing effect, which is very similar to cocaine. So it's certainly not a drug for chronic treatment. Finally, forced hydration. We have done that for many, many years, flushing out the stone. What about that? There are very few controlled studies, and the best is the one from Glenn Preminger's group 6 years ago. 43 patients, renal ureteral stones, non-steroidal plus morphine on request, and hydration intravenously, either a minimum hydration, 20 ml per hour, or a forced hydration, 500 ml per hour, randomized. The delta pain on a visual analog scale was not different with forced versus a minimum hydration, nor was the need for morphine equivalents or the percentage of stone passage. So there is no effect of forced hydration. Moreover, you can get rupture of kidney pelvis with forced hydration, and I still believe in this quite old statement. It's now 22 years old from British Medical Journal. We recommend that patients with renal colic should be kept normally hydrated. The overhydration of patients with renal or ureteral colic has no physiological basis. It is at best pointless and at worst dangerous. So what I would like to suggest as a treatment of renal colic, point 0, no forced hydration. Start with a non-steroidal. It's mandatory if not contraindicated. There are drugs available like diclofenac, which you can give orally or intramuscularly, or you have ketorolac, which you can give intravenously. Then I always would add an expulsive treatment with an alpha blocker. I'm going to talk about that tomorrow. As a second step, a non-opioid, paracetamol, surprisingly good, or novamine sulfone, 500 to 2,000 milligrams intravenously. And the third step would be an opioid. In an emergency, you can always use the pethidine once or twice, or you can use the morphine, it's similar, but no pethidine for regular treatment longer than 24 to 48 hours. If colics are ongoing and you do not intervene, then you should use an oral long-acting opioid, which is preferred, for instance, oxycodone, 10 to 40 milligrams every 12 hours. And with that, I thank you for attention.